So why don't we get started? Thanks for taking the time to join today's webinar focused on expedited partner therapy, or EPT. My name is Arik Marcel, and I'll be facilitating today's session. I'm an adolescent medicine physician at Johns Hopkins Harriet Lane Clinic, where I direct adolescent health services and the Title X program. And today, I have the pleasure to be joined by Elizabeth Lebo. She's the chief of the Division of Policy Planning and Communication in the Center for Sexually Transmitted Infection Prevention at Maryland Department of Health. And for the past 25 years, she's worked in the state and local public health areas of maternal and child health, sexual and reproductive health, and infectious diseases. She's been involved with planning and implementation of EPT in Maryland since 2011. And we also have the pleasure to being joined by Dr. Janelle Coleman. She's an associate professor in Johns Hopkins School of Medicine, Department of Gynecology and Obstetrics, and she's the chief of the Division of Gynecological Specialties. She's a clinical expert on comprehensive gynecologic care of women from adolescence to menopause, and she has particular interest in reproductive health care among disadvantaged or marginalized women, including women who inject drugs, sex workers, poverty-stricken women, and women living with HIV. For today's webinar, we'll have 3 segments. In the first 10-minute segment, Ms. Lebo will provide an overview of EPT, including current law and implementation regulations here in the state of Maryland, and why EPT is an important public health tool. In the second 10-minute segment, Dr. Coleman will briefly talk about her experience implementing EPT in clinical practice and challenges to its implementation, and how she addressed these challenges. And finally, in the last segment, we should have about 20 minutes to take your questions using the Q&A function at the bottom of your screen, including any issues you've had providing EPT right now during the pandemic. Please stick around to the end to answer 3 polling feedback questions about the webinar, and everyone who answers all the questions will be entered into a raffle to win one $50 gift certificate from the local Ivy bookstore in Falls Road. During this pandemic, we've seen a lot of changes in our clinical practice, including use of telemedicine and increased use of phone triage. And we expect to see more changes as this pandemic waxes and wanes through our region over the next year. It's our goal that by the end of the session today, regardless of the changes we experience, you'll have the needed tools to incorporate EPT into your practice. So let's start with Elizabeth, who'll share a brief overview of EPT in the state of Maryland.
Hi, everyone. Can you hear me and see the slides? I'll look for a chat in the chat box if that is not the case. I'm going to try and turn the video on. I'm not sure if you can see us. Oh, I guess it is working. Good afternoon. Thank you so much to Dr. Marcel and Dr. Jackie Jennings at the Hopkins Center for Community and Child Health Research for inviting me to present in this webinar. I'm going to talk very fast and go through a lot of slides, some of which are extremely quick and just quick snapshots, but the slides will be available later so you can go back and review them later. Bambi, can you go ahead to EPT overview? So we save time here. Okay, so the first EPT overview slide there. So EPT, expedited partner therapy, if you're not familiar with it, is not a mandatory practice. It's a voluntary clinical practice of treating the sex partners of patients who are diagnosed with STIs by providing either prescriptions or directly dispensed medications for them or their partners, for them to give to their partners or for you to prescribe to their partners without an intervening medical assessment. And I just want to say here quickly that some states require that those STIs, chlamydia, gonorrhea, have to be laboratory confirmed. And here in Maryland, we have said in our statute, our law and our regulations that chlamydia, gonorrhea, and trichomoniasis can be laboratory confirmed or clinically confirmed. So their EPT is intended for partners who are unable or unlikely to obtain timely testing and treatment. And it's a very useful tool in our toolbox. It's a partner treatment option, especially during COVID, that can supplement, not supplant, traditional partner management, including partner treatment. Back in 2006, the CDC issued its recommendations in a white paper where they recommended treating heterosexual partners of patients with chlamydia and gonorrhea through the use of EPT. Many states have added on trichomoniasis. Some only include gonorrhea in their, chlamydia rather, in their EPT laws. It's a broad picture across the country. It is, though, endorsed by almost all national professional societies that are medical societies, Academy of Pediatrics, OBGYNs, Academy of Family Practitioners, the AMA, and interestingly, the American Bar Association. Next slide. Great, thanks. So the basic purpose of EPT is mostly to reduce the likelihood of reinfection in your patient, the index patient, because reinfection is common, very common in women and in adolescents. And adolescents really bear the brunt, especially females, of long-term sequelae and harm from untreated STIs. So the other purpose is to prevent long-term sequelae, including PID, infertility, potentially fatal ectopic pregnancy, chronic pain, and also the increased risk of HIV acquisition and transmission that go along with having an STI. And finally, to halt further individual and community transmission. Next slide. So there are a number of potential barriers to implementing EPT. We're not going over them today except for one or two. Medical legal liability concerns are chief among the barriers to having EPT implemented. Some states have liability protections in their laws. We do not in Maryland. There are lots of operational barriers in terms of the time needed to educate patients, difficulty issuing prescriptions through an EMR, cost. So we'll just talk about one or two of those. So I do want to mention, this is really important, given that liability is the biggest concern among clinicians and pharmacists. I want to note that California was the first state in the country to legally authorize the use of EPT, and they set up a toll-free hotline for years. They had absolutely no calls to their hotline about any adverse reactions, reports of lawsuits, and no one else in the country that I am aware of and that national organizations following EPT are aware of have heard of any lawsuits arising from EPT. Okay, next slide. Thanks. Oh, go one more, I'm sorry. So the legal picture nationwide is that there are very few states that are not legally authorized to practice EPT for their clinicians and pharmacists. So you see only one. South Carolina has it explicitly prohibited. Several have potentially allowable EPT, but we are in good company with the rest of the nation. Next slide. EPT in Maryland, I mentioned we have permission, legal authorization for clinicians and pharmacists to engage in EPT for chlamydia, gonorrhea, and trich. Wide endorsement from a number of Maryland clinical societies, the State Health Department, and the Medical Society. Next slide. Just super quickly, I want to mention that you may know we are really at a crisis point with STIs across the country. They have been rising every year. The three notifiable infections, chlamydia, gonorrhea, and syphilis, have been rising year after year for at least the past 5 years. We won't have our 2019 published until, for Maryland, published until a little later this year, and the national data will not be coming out due to lags and COVID response efforts until probably early next year. Next slide. So just very quickly, the picture in Maryland is the chlamydia has risen. There has been over a 6.5% increase in reported cases of chlamydia from 2018 to 2019, just that 1 year jump. And looking at a 10-year trend from 2010 to 2019, nearly a 40% increase in the rate of infections. Next slide. For gonorrhea, we see an equally troubling trend, 12.5% increase in reported cases just in a 1 year period from 2018 to 19, and a 50% increase in the rate of infections over the decade 2010 to 2019. Next slide. Thanks. So just to show you the drop-off in reported cases during the pandemic, we see a 40% increase. We mentioned, actually, let me just point out from, I don't know if you can see on the, I don't have the capacity to use a laser pointer, but the drop-off in reported cases of both chlamydia and gonorrhea in Maryland is not likely due to a real true decrease in infections. Rather, it is the fact that clinical services and the capacity to do STI testing basically shut down when the governor issued the stay-at-home order in Maryland in March. Next slide. Thanks. And then we'll go one more ahead. So who pays? So a patient can pick up a prescription for the partner and pay out of pocket, or a partner can go in, him or herself, to the pharmacy and pick up a prescription. If that partner is insured, insurance will cover the cost of the antibiotics, and Medicaid also covers the cost of the antibiotics. If a partner does not have insurance, he or she must pay out of pocket. And some federally qualified health centers and health departments may directly dispense medications from the office to the patient to bring to the partner at no charge. Next slide. So these are the healthcare providers who are authorized in law to prescribe or dispense EPT. I'm going to just race through these because of time. So physicians, physician assistants, advanced practice registered nurses, and some health department RNs who've been through special training. Next slide. So there is no limit in Maryland to the age of a patient who can be given EPT to give to their partners, no limit on how many partners can be treated. And we did not include in our statute or regulations any prohibitions on giving EPT. We left everything up to clinical judgment and did put caveats in clinical guidance. So patients obviously who are co-infected with an STI that isn't treated by the treatment for chlamydia and gonorrhea and trick cannot be treated through EPT. Patients with HIV and not in care, men who have sex with men, we are concerned about routinely offering EPT to those folks because of the high rates of syphilis and HIV co-infection and the high likelihood of oral gonorrhea and the concern about gonococcal resistance, antimicrobial resistance to gonococcus, which is a sneaky bug and has developed resistance to every class of antibiotics it's ever seen. Any patient with documented or suspected history of child abuse or intimate partner violence must not be given EPT. Next slide. Just a super quick note, minors consent in Maryland. Minors under the age of 18 can consent to and receive confidential sexual and reproductive health care, including STI treatment. And as of last October, minors in Maryland can receive PrEP. Next slide. If you have a woman who's pregnant and you have any questions about EPT, please call your local health department. The disease intervention specialist may be able to assist you in notifying pregnant partners or the partners of pregnant patients and help link them to testing, treatment, and care. Next slide, we'll skip. Prescribing. The drugs prescribed have to be in line with the current STD treatment guidelines from the CDC, which will be out again. The next version will be out in 2021. Next slide. Every prescription has to indicate EPT or expedited partner therapy somewhere on the prescription, and double dosing is not allowed. You may not write a prescription, say, for 2 grams of azithromycin, one of which is intended for your patient and the other gram of which is intended for the partner. That's insurance fraud, basically, and not allowed. If the partner's name is known, it must be included on the prescription. Maryland does allow the issuing of prescriptions to an unnamed sex partner. So if your patient doesn't disclose their partner's name or doesn't know it, that is fine. You just issue the prescription to EPT, and that is sufficient for the pharmacist to fill the prescription. They may refuse even if the name is on the prescription. That is their right, but it is also legally allowable to issue a prescription to an unnamed sex partner. Next slide. The same goes for dispensing. Labels have to include EPT, and if the partner's name is known, it must be included. Next slide. This is just a super quick picture, and then the next slide of some paper prescriptions where EPT is noted. Next slide. Clinicians have to counsel their patients who are being given EPT to take to their partners, including urging the patient to tell the partner, even if they've already taken the EPT meds, go and get a clinical evaluation. You can go to the next slide. I just want to show you really quickly that we have fact sheets for patients and for their partners for both chlamydia and gonorrhea and trichomoniasis now. And next slide, we've got fact sheets for healthcare providers. Next slide, fact sheets for pharmacists. Next slide, EPT does have to be documented in the medical chart. You do not need to put the name, and probably shouldn't be putting the name of the sex partner because of confidentiality issues, since that partner has never been tested and diagnosed actually with chlamydia, gonorrhea, or trick. But what you need to report in your medical documentation is the number of prescriptions you wrote or medications you dispensed to the patient for each partner, and then the dosage. Next slide. Provider reporting is required. A lot of providers are not aware that they, by law, must report notifiable diseases, including chlamydia, gonorrhea, and syphilis. Trick is not reportable, but these are the COMAR regulations referenced here for reporting. Next slide. Thanks. This is the Maryland Confidential Morbidity Report form. Next slide. And this is a little zoom in of, and the formatting I was using standard slides and they went to widescreen, so the formatting is off there, but you can see it's, this is a zoom in of the section about EPT reporting for the number of partners. Next slide. That is it. There is my email address. I'm happy to take any questions and look forward to helping do grand rounds, hospital grand rounds, or any other information you want, we can help provide, or in-service trainings. Thank you.
Thank you, Elizabeth. Now let's move on to Dr. Coleman, who'll share her experience in implementing EPT in her clinical practice.
Yes, good afternoon, everyone. And thanks to the organizers for inviting me to share all the work that we've been doing here at Hopkins, where I'm medical director of our OBGYN clinic. Next slide. So Elizabeth went over some of this. This was basically a paper that we had written for an OBGYN audience, just debating sort of the pros and cons of EPT, because we realized that lots of providers were not prescribing EPT. So Elizabeth already mentioned some of the pros, but some of the cons and reason why providers have stated that they are concerned about it was, number one, is limited screening for STIs in the sexual partners. And for OBGYN clinics in general, we do not have a mechanism to include care for men. And one of the key things that comes up a lot is whether or not the partner will have an allergic reaction to the medication that is prescribed. And that is one of their concerns about prescribing EPT. We've talked about pharmacists' refusal to fill the prescription, and then the cost that may be associated with it for the partner. Next slide. So in terms of partner therapy, this is just a slide to show for all of the oral regimens, and that partners within the past 60 days can be offered EPT. And if the patient has not been sexually active in the past 60 days, then the most recent sexual partner. And basically, we say to abstain from sex for about 7 days after both or all partners have been treated. Next slide. So once EPT was legal in Maryland, I was really excited and pretty much decided to do a QI project for our clinic, and involved a lot of students and folks who actually were very interested in this. So because we were on electronic medical records, we decided, okay, how are we going to do this? We had written prescriptions that were available for use in our clinic, and we created all of these labels to make it easy for our providers to actually use EPT. So we created these EPT packs, and at this time it was just gonorrhea and chlamydia that was allowed. And with these packets, we put on stickers that said EPT in the name line. We had the dosage and the medications listed, so that all the provider had to do was actually just sign their names and provide the educational material to the index patient. Next slide. Next slide. Okay. So throughout this time, we launched this project. We learned an awful lot about EPT and just the workflow, because conceptually it sounds really easy, but to actually make this happen in clinical practice was actually quite tough. So the first thing was just knowledge about EPT, and that was for some of our providers who were not aware that it was allowed by law. Patients did not know about it. I can say now we do have some patients coming to ask for it, which is nice. And then we realized that lots of pharmacists were denying some of our prescriptions. The other issue that we ran across was just insurance coverage for the partners and the whole issue behind using electronic medical records, which I'll talk about in the future. Next slide. So decided, because I'm a researcher also, was okay, let's write up our experience of starting off EPT in Baltimore City at a large OBGYN clinic. So I had a student who created this infographic that what we did was we got a list of all the pharmacies in Baltimore City and surveyed them, called them about EPT and whether or not they were aware of it. We asked them about the cost of, the dosages for either chlamydia or gonorrhea. And what you can see here is that the average cost or the median cost across Baltimore City pharmacies was $30 for a dose of azithromycin, but it ranged from anywhere from $5 up to $40. So we realized for some of the partners, this actually may be a barrier. The other thing that we found was that for most of the pharmacies that were accessible and open, when we overlaid that with the incidence of chlamydia in the city, we realized that there were not a lot of pharmacies where there are high rates of chlamydia. And then the last thing we noted was that pharmacists were really not aware of EPT. And this was kind of early on a few years ago when EPT was just sort of allowed in the state. So about 18% were allowed. The neat thing is that we asked a question about, even if you were not aware of it, if you were presented with a prescription, would you fill it? And the majority said they would fill the prescription. And a small number had actually received an EPT prescription in the past. Next slide. I'm not going to go over everything here, but I work a lot with colleagues in Michigan. So at the time that we were launching EPT here using paper prescriptions, Michigan had already sort of worked through a lot of the kinks. And my colleagues here had written a really nice review article at AJPH that basically outlines like all the steps that are involved with prescription EPT. So when you have that sexual partner, the index patient, and you actually have to give them a prescription, there's so many different steps that has to happen in order for the partner to get treated. Next slide. So Michigan, so I asked them, I was like, okay, please tell me what you guys are doing, because they were in electronic medical records. So this is an example of an e-prescription that they had in their EMR, which was Epic. So they shared this with us because I was trying to get our team here at Hopkins to adopt this. And you can see with Michigan as well, they have a blurb down the bottom as a note to the pharmacist, just in case pharmacists were not aware that EPT existed. They added this information to help the pharmacists understand that it is legal in the state of Michigan. Next slide. So then our Epic experience, and this was a little challenging, so I'm going to take you guys back a little bit. Next slide. So this was back in 2015. So as soon as I realized that we could do EPT in Maryland, and we were working through all these paper prescriptions, which from a workflow and clinical standpoint, it was very problematic. So I had requested to have something built into Epic, just like Michigan had. And there was an institution in Massachusetts that I spoke with as well who had something in their EMR. So you can see here my whole timeline. From 2015, I requested this. For over, it's almost like a year and a half, there were like multiple emails back and forth with Hopkins leadership to try to make this happen. And then in April 2017, I received this long email basically stating that we couldn't do it. And some of their reasoning behind it was actually the EPT law. So they said things like, well, they were concerned about a slippery slope, that if we started with STIs, we may start treating other things without having a relationship with the partners. They also were concerned about documentation in the record. They were concerned about allergies. So pretty much they were just pointing to issues that I had mentioned had already been worked through with the law, but basically it was led to a dead end, didn't hear back from them. Next slide. And so we went back to our paper prescriptions, talking about EPT with as many people as possible. Next slide. So the way that the Epic build actually happened. So after all of this frustration, Elizabeth, who spoke earlier, actually introduced me to an Epic physician builder who actually can create things in Epic. And that happened in 2018. Next slide. And basically, we worked through all the kinks, like just getting this into the system. Like you had to figure out how this was going to be structured, how many partner packs would you allow, how do you get educational material into it, how to link to all the different drugs and things that were stored in the electronic medical record. And we knew that we did not want to have this inside the index patients chart, which was really important. Next slide. So this is what our Epic Smart Set actually looks like. So it was built that same year, which was really exciting. We had to work through some kinks with this, but it was really exciting when it first happened. So as you can see here, this was when, I'm not sure if Trick was allowed yet, or we had it included. So initially it was for chlamydia and gonorrhea. And you can see here, there was a way to click off like the diagnosis. At the bottom, you can see where we had options for providers to treat patients, the index patient in clinic versus sending something to pharmacy. And then we had click off boxes for prescriptions for partners, as well as some of the educational materials that you can include. Next slide. So this is what our final kind of today's EMR EPT looks like. So on the left-hand side, you can see that's an example of the prescription that is actually printed out, which is really important. And I'll get to that in a moment. So that's printed out, has to be signed by the provider and given to the index patient. And then you can see on the right-hand side, this is an example of the educational materials that are word for word from what the state had published, and we just uploaded it into our EMR. So we have them for chlamydia, gonorrhea, and trichomoniasis. Next slide. However, I can say that it was still a bumpy road. We're doing really great, but there is still some work that needs to be done. Next slide. So the first thing that happened when we got this into our EMR was that the patient's, the index patient's name continually showed up on the prescriptions. And that was problematic because, for one, for HIPAA purposes. For two, like pharmacists were really confused about what was going on because we had a patient's name. It was just in kind of like the header in the footer, even though it said EPT. But I can say that took probably another like 6 months to work that out. So now for Epic, everything is clear. We do not have the patient's name on there no longer. The other thing was that providers, even though we had all of this, they're so used to electronic e-prescribing that, you know, the prescription goes straight to the pharmacy. And that happens for all the other medications. However, for EPT, there is no way for us currently to send a prescription electronically to the pharmacy. And that is because if the pharmacist receives a lot of these like EPT prescriptions and folks start coming in, they don't know which prescription belongs to whom. So right now it has to get printed out. And this was problematic for lots of our providers because, number one, they may not have been aware of that. So they're thinking they're sending the script to pharmacy where actually they were not. And then it's like, if they did print it out in the way that with minimal interaction with patients, it was like, how do we get this prescription to the index patient? So for us, we had a whole system in place where we would send it to our nurse who would print out the prescription, get it signed, and they would mail it to the patient. Or if they were coming in for another appointment, because lots of our pregnant ladies, actually, we allow them to have EPT as well. So we would give them the prescriptions when they're there for a visit. And I can say that there are still some pharmacies to this day that would refuse to fill the prescription. And I can say, luckily, though, they usually call us and say, we're unsure about what is this EPT, and then it just involves some education. Next slide. So this is just to give you guys a sense of the clinic. So I have the years down below. 2017, this is before our EMR launch, when we were just using paper prescriptions. 2018 was when the EMR launch happened, and then 2019 afterwards, and for the different infections. And so I have an arbitrary line. Blue and red meant that providers were actually asking patients about whether or not we're offering EPT to patients. So that took a lot of sort of educations on the provider side of things. And you can see for chlamydia and gonorrhea, they do an awesome job of offering almost all the patients EPT. For trick vaginalis, because that's relative, that was added on later in terms of the law, there's still a little bit lag there, but I can say in 2019, we're getting to the point where almost all of our patients who are testing positive, we actually offer EPT. And you can see that not all patients, which is in red, not all patients actually accept EPT, which is fine. Next slide. So that's the end of the talk, but I wanted to say it was a bumpy road, but the thing that I realized throughout all of this was that it definitely was teamwork. So it was like pressing forward, having a lot of sort of trainees who were interested in helping out, knowing Elizabeth, and some of the EPIC folks to actually make this happen. But I'm happy to say that it's up and running, and we're trying to figure out ways to e-prescribe, but that's a whole other sort of discussion. But thank you.
Well, thank you both for your really informative talks. If anybody in the audience has any questions for either of our speakers, can you please write them using the QA function on the bottom of your screen rather than the chat, so we can track answers. And I have a couple of initial questions, and then I see one question from one participant. Participants, when registering, identified a number of barriers to providing EPT. One of the most common barriers, about 17% of registrants cited, not knowing medication allergy status of the index patient's partner. How do you assess that in your clinical practice, or do you?
Right. So I can say for us, this is something that we talk about a lot. And I think one thing that's helpful for us, because we are OBGYNs and women's health providers, we think a lot about kind of the adverse sequelae that happens to women, mostly if their partners are not treated. And we see these repeated infections and ectopic pregnancies. So I can say most of our providers are actually a little bit more comfortable with this. So as part of the educational material that has to be provided, there is a sheet that is specifically for partners. And in that material, it talks about allergies, as if they have an allergy to the medication that's prescribed, they should not take it. So this is something that we do discuss with our patients, that we give them an info sheet for themselves as well as for their partners. And we do make a point of mentioning that if they have any known allergies to the medications, to definitely not take it. The other thing that we noted is that just in terms of, for like chlamydia, or trichomonas is our two most common types of infections where we give out EPT. We just know that allergies, like severe allergies for azithromycin, are quite low. Probably like less than 1%. And then with the metronidazole or tinidazole, I mean, allergies are not that common. So put it all together, it is something that there is that risk that's there, but in terms of does it really happen, we hadn't had any experience with any bad or adverse outcomes with prescribing EPT.
May I also add that, a pharmacist has yet another opportunity to ask about allergies if the partner, him or herself, comes in to pick up their meds, or if the patient comes in to pick up the meds for the partner and the patient happens to know about any drug interactions. But again, azithromycin, it's a fixeme, and metronidazole, they're so safe. And we, again, have heard of no adverse reactions nationwide, going back to 2001 when California implemented EPT. So it is a concern, but it hasn't borne out in terms of adverse reactions.
And I pasted in the chat the Maryland Department of Health phone number, but also the email address if there's any experienced adverse events to share so that they can track.
Yeah, better just that clinical consult line actually goes to me anyway, the email address, and the phone number. Our offices are closed, so that line doesn't get answered immediately. So feel free to reach out to me directly, especially during COVID. I'm happy to.
And I have another question from an audience member, if folks are treating vaginal or penile discharge syndromically via telehealth without testing, what are you doing regarding EPT? They reflect, they understand it may be legal without testing, but from a clinical standpoint.
Right. So I mean, I can comment on that. So our practice actually was a little different during the height of the COVID epidemic, so that we still saw patients, or we had patients self-swab. So we still had a diagnosis for our patients. And also because we do prenatal care, we did not stop the pregnant patients from being seen. So I can say that personally, I don't have a lot of experience with syndromic management since we were still testing our patients, but I know that it performs poorly. So in terms of knowing actually which infection that a patient may have, I think for women, and I can speak to that just because I'm OB-GYN, for some of their symptoms, it's quite clear just based on how they describe it. I can pretty much predict what they would have. But I wouldn't feel comfortable myself prescribing all the medications that for any type of infection that a woman could have, because vaginal discharge, there's a long list of different type of infections that could occur, and we know the data shows that syndromic management is terrible. But if you have a high suspicion that your patient through telehealth may have an infection, an STI that you can use EPT, then I guess, I mean, I personally would feel comfortable giving out a prescription to their partner if I really thought that they had an STI.
Yeah, and in our clinical practice, we really didn't stop seeing patients, especially in the March, April, May, who were presenting with symptoms. Probably, I too have less experience in treating syndromically and then providing EPT as part of that. But for those individuals who are coming in, we were providing EPT, to patients as appropriate.
We can also post, Dr. Marcel, we can post later. I don't have it at my fingertips, but the CDC syndromic management guidelines during COVID.
And we held 2 prior webinars, and those are both were recorded on our website. So you can contact the email that's listed on the slide to get the link to view those that review the syndromic management approach. So there was another question. In your studies, have you noticed a difference in barriers to accessing EPT at retail pharmacies versus in-clinic pharmacies?
Yeah, so I can say that's actually interesting. So the retail pharmacies were quite challenging because we were trying to figure out, when we first launched, we had so many denials, patients calling back saying the pharmacist won't take it, pharmacists calling us. And we were trying to figure out how to tackle this. So we actually contacted some of the large retail pharmacies like Walgreens and Walmart to try to figure out how could we sort of have more education. And that kind of was just actually very difficult to do given how they're distributed across the nation. So then here at Hopkins, we tried another route, was we contacted our pharmacists here and we had the pharmacists involved. So I didn't present data on that, but we collaborated with our pharmacy colleagues here who actually had a say with like the Maryland Pharmacy Board. And so they started giving out educational talks. And so at least internally, if they received an EPT prescription, then like the folks here were all aware of the whole process and that it was legal. So, and then I can say immediately around our clinics, the pharmacies that are there, they are all aware of it too, just because I think we blasted them with so many prescriptions and spoke to them a lot. And then I know the health department did detailing as well. And I'm not sure, I think they went to the pharmacies to try to increase education, but I think that was an effort to try to get a lot of pharmacists just to increase their awareness that this is a legal process.
I'd like to also say, contact me separately if you're interested. We had an article published a few years ago in Maryland Pharmacist Journal about how to create a profile in your pharmacy database for an unnamed sex partner, which was by far the biggest concern about how do you even implement this. And we can't monitor this because there are multiple pharmacy databases and they don't all speak to each other. So there's no way to monitor EPT prescriptions statewide, but there are workarounds. So happy to talk about that with anybody.
One of the other next cited barriers that registrants discussed as part of the registration process was relating to not being familiar with actually seeing the state regulations. And so I posted in the chat links to Maryland specific documents that review the actual state regulations and then speak to the COMAR, but also the more general CDC link for that taps into the slide that you, Elizabeth, presented for audience members who may be practicing in a different state. And another question from a member of the audience asked, are there problems with Cefixime availability? Have you seen any issues with Cefixime being available in local pharmacies?
We've been monitoring, we've been assessing STI and family planning clinical capacity at the health department level since March every month, and prep capacity of our programs. And of the approximately 50% of health departments that even have the bandwidth to respond to our monthly surveys, have responded to our question, are you experiencing any drug shortages, or are you aware of any of your community clinicians experiencing drug shortages, including, Cefixime, ceftriaxone, azithromycin? And they have said no. There was one reported that she's actually heard that syringes are now on back order, so that's a concern, obviously, for bicillin and ceftriaxone, which don't affect EPT. But nationwide, there have been reportages of azithromycin back orders and shortages due to the whole COVID, using azithromycin for COVID, but we expect that to hopefully improve over time. On the CDC website, there's a list of national drug shortages right now, and you can also reach out to me. We do want to keep our finger on the pulse of any drug shortages you're hearing about in your pharmacies or communities, so please reach out and let me know. CDC wants to be informed immediately of any drug shortages we hear about.
And if any audience members have a need for additional detailing on EPT specifically, or would like access to actual hard copy script pads, if you don't currently have anything in for your practice, please email the email listed on this slide, cchr@jimmy.edu, and our members of the project team will reach out to you and provide you specific documents, toolkits, script pads, to support your EPT practice. So I realize we're just at the hour. In our final minutes, I'd like to thank our presenters and have you also complete 3 short questions about the webinar. And again, everybody who participates in this, will be entered into a raffle to win one $50 gift certificate at the local IB bookstore on Falls Road. And if you have any other comments or questions to share with us, please write them in the chat. And like I said, if you need any additional trainings on topics or specific information about EPT, including script pads, please email us. Thanks again for participating in today's webinar, for your intention and insightful questions. And finally, I'd like to thank our sponsors today and speakers as well. The sponsors include the Bureau of HIV/STD Services at the Baltimore City Health Department, the Center for STI Prevention at the Maryland Department of Health, the STD HIV Prevention Training Center at Johns Hopkins, and the Center for Child and Community Health Research at Johns Hopkins School of Medicine.
Yeah, this has been great. The one thing I would like to add, so with all of our EPIC EMR stuff, if anyone needs assistance with that, please feel free to reach out to me, because I feel like I've been through the ringer with all of that, and I'm more than happy to help people get the EPIC smart sets available at their location. Thank you, guys.
Thank you, everybody.